I'm honored to present to you today on behalf of the folks from Dendreon has been my experience in immunotherapy. And I'll tell you a little bit about my experience in immunotherapy, why it's just been a remarkable, great year for prostate cancer. We have this amazing pipeline, as was witnessed this year by the FDA approval of Sipuleucel-T or Provenge in April. But prior to 2004, we didn't even have a chemotherapy to impact prostate cancer. 2004, we saw the approval of Taxotere. This year, we see the approval of Provenge for advanced prostate cancer, the first vaccine, the first therapeutic vaccine approved to treat any solid tumor. Thanks to research, thanks to your support, thanks to funding, thanks to people's dedication. And so the thing that worries me is that the challenge is we have this therapy, which I'll tell you more about. We have all these other great therapies that are out there. And the sad part is that over years of what we had, this nihilism in my profession, well, we can't do anything about advanced prostate cancer. We can only treat it locally. Now we can't treat it systemically, but now we can. But the sad part is that we're having this economic crunch in terms of reimbursement and more importantly, for future research. So we sit in a room like this today and I look out and I see 75, 100 people and I think, wow, you can have an enormous impact tomorrow and in the future days of making sure that we don't let this incredible pipeline, this incredible opportunity fall away. It's just in the last few years that we've had it. We have to make sure that in addition to keeping funding within the government, which isn't a lot of money in the scheme of things, but we compete with other cancers and other diseases which also need funding, whether it's cardiovascular, AIDS research, etc. But we also need to make sure that you advocates please get your community doctors, my colleagues, urologists, other oncologists, get them involved in trials. Tell your doctor, hey, why aren't you doing clinical research? It's really important. Why aren't you, if you're not going to set up your own program, get people to somebody who will enroll patients in trials. Because if you think about comparative effectiveness and best use of research dollars, the quicker you accrue trials, the quicker we get answers. That saves an enormous amount of money in terms of all these budgets. Slow accrual is death to research development. So we need the funding, we need to get patients accrued, we need more of the community doctors involved. So, what is Provenge? It's an autologous cellular immunotherapy. It's a mouthful to say that, but essentially what it is, it's a personalized therapy allowing you to re-educate your own native immune system for advanced disease prostate cancer, where the PSA is rising despite androgen deprivation therapy. It is the first therapeutic vaccine for any solid tumor ever approved. And here's the one important take-home curve. It's a Kaplan-Meier curve, which basically shows you the trial comparing Provenge to a control group. These were patients who had rising PSA, evidence of metastatic disease, positive bone scan or CAT scan, typically positive bone scan, and they were randomized 2-to-1 getting the therapy, the immunotherapy, which is essentially completed over a month. Takes place over a month, not over 9 months, not over 7 months, it's over in a month. 3 infusions, 3 intravenous infusions. In the key data, you see the separation of the curves that there's a 25.8 month survival advantage versus 21.7 months at 2 years. So at 2 years, there's already a 4.1 month survival advantage, which translates to a hazard ratio of 0.775, which means there's a 22.5% reduction in the risk of death to the patients who receive the immunotherapy. Again, here's another way. It's a complicated slide, but if you look at the 12-month, the 24-month, the 36 months, and you look at the Provenge versus the control arm, look at the percentage of patients who were alive. And you see it consistent across this spectrum. So essentially a 4.1 month median survival advantage. 4.1 month, essentially a 30 to 40 day treatment, and whereas docetaxel was approved in 2004 over a 9-month therapy with a much, much more significant toxicity profile. Next slide, please. And so I was involved in this trial, and I enrolled 18 patients in this trial in my clinic. And I'm now prescribing it, now that it's been approved in my clinic, on label. And I can tell you, the thing that really was very heartening to me, and again, we do have some decent chemotherapy, there's no doubt about it. And we have this really robust pipeline of oral molecules. But in this immunotherapy, which was so wonderful to see, was that how well the patients tolerated the therapy. And if you look at the adverse events here, the most common adverse events, it's really about having fever, chills, and some muscle aches. Those were the statistically significant differences compared to the control or the placebo arm. So fever, chills, and muscle aches. Not the usual things that we oftentimes see with chemotherapy, where there's lowering of the white blood cell count, which makes one susceptible to infection. There's no hair loss. There's really minimal gastrointestinal issues. So a very well-tolerated therapy, and thus quality of life. Quality of life is something that we need more data on in all the therapies we do, not just in prostate cancer, and not just in cancer, and a lot of the other non-oncological things as well. So the most common adverse events were mild to moderate in almost 70% of the patients. And I think that's really important when you're dealing with an elderly population as a general rule. Most men, when they get to this stage, are typically going to be in their mid to late 60s to mid to late 70s. Not all. There are, unfortunately, men in their 50s, early 50s. I have them in my population. They actually can tolerate more aggressive therapy sometimes. But it really is remarkably well tolerated. And the last bullet shows you that about 92% of the patients received the complete course of therapy of Provenge in the trial, which is essentially harvesting your white blood cells in a process called leukapheresis. It takes about 3 hours. You sit in a chair. It's much like almost donating your own blood, and then you go home. You come back 3 days later to the clinic, and you undergo a 1-hour infusion. What's happened between the time that you had your peripheral blood cells harvested, they're sent to a special treatment processing plant where they combine your specific individual cells with a special fusion protein that then helps to re-educate your derivative white blood cells. We call them antigen-presenting cells. These antigen-presenting cells are then learn how to recognize a certain protein called acid phosphatase antigen to then be reinfused back into the body 3 days later. In my office, in my clinic, over about 45 minutes to an hour, and patients go home. This happens 3 times over a month. So these are the worst adverse events, the grades 3 to 5. And what you can see comparing, really these are very, very significant adverse events, comparing the Provenge arm to the control arm, which essentially was just getting back an infusion of their peripheral blood cells, that essentially no statistically significant difference in these really bad events. So this is really a game changer right now, and it's really a milestone event this year. We can no longer practice silo science. We all have to work in this together. We don't have unlimited funding. We have to combine the resources of industry with the government, with advocacy groups. We have to combine academia with the community physicians so that we accrue trials faster. We do this in a cost-effective manner. It's such a great time out there. I just don't want to see us miss this opportunity because of lack of funding.